Welcome back to Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by Dr. Jarrod Shapiro. Thanks for hopping on with me tonight.
Thanks for having me.
Yeah, absolutely. Most people are probably aware of you just from, school and residency, and then your involvement with podiatry.com, Present Podiatry. But for those who aren't aware of you, why don't you give us kind of a quick backstory of who you are and where you came from?
Yeah, absolutely. So I grew up basically in Arizona, and then went to podiatry school at Samuel Merritt. It was then the California College of Podiatric Medicine from 99 to 2003, and then trained in Michigan at the then Botsford General Hospital program in Detroit. During my third year, my senior year, I was approached by the Present folks, Michael Shore and Alan Sherman, and they were looking for somebody to write from a residence standpoint. So I took the plunge and started writing. That has now gone on for almost on 20 years.
Wow.
I think I'm on the, I don't know, 950 something editorials, and I've been pretty
Yeah.
consistent over the years.
Yeah.
Um, so as that went on, I was just like really any other podiatrist. I was in practice for about 4.5 years, first in Lansing, Michigan, and then in Oregon for a couple of years. I was then sort of tapped by Larry Harkless, the founding dean of Western University, where I interviewed and they asked me to join them, which I was amazed that anybody would even rightly want me there, but they did. And so I ended up there for about 14 years, was there pretty much for about a year after the school started. And I'm still there as a part-time professor, and I'm in private practice. So again, just really like anybody, I'm in practice. I do surgery, I see patients, I teach, I run a podiatry residency program that's based out of Chino Valley Medical Center. That program has been in existence since about 2013, and we're getting to be increasingly bigger as time goes by. We now have 4 residents per year, so about 12 residents for the program,
Mhm.
and it's been a lot of fun. I've gotten a chance to really see all the different aspects of podiatry, whether it's practice, teaching, different practice environments, whether it's surgical, hospital based, wound care clinics. I've done a lot of those things, and I've been really lucky to take the knowledge that I've learned and the experiences and frankly the mistakes, and to be able to communicate those to the community. So it's been really a lot of fun. I've really enjoyed podiatry as a career, and I'm always very positive about it as a career. I think it's a fantastic one.
Mhm. I think it's interesting that you said mistakes, because I think if you ask anyone who goes to a conference, usually the things they learn the most are what other people tried that may have not been overly successful and how can they avoid those same pitfalls. So I think that's important when it comes to education, whether we're educating students, residents, colleagues, whatever it may be, because sometimes you don't know what those mistakes are until you try something new and then you find, okay, well, maybe that didn't work. Next time I'm going to do this. But I think that's kind of an interesting perspective to be at least aware that including your mistakes, because it takes some amount of humbleness. I don't even know if that's a word, but it takes being humble to being able to tell people like, hey, I tried this, don't do that, right?
Oh, absolutely. I would love to see more of that in our conferences. Just maybe an open forum where people can show that they've tried something and maybe it didn't work as well, or maybe it worked in somewhat, but the "in my hands" comment that is kind of hard to translate to reality. There are
Mhm.
reasons why something might be better in someone's hands than others. I think
Right.
you're right. It's really good to be able to talk about your mistakes. With the residency program, we actually spend a lot of our educational academic time talking about, how can such and such procedure have been done better? What
Mhm.
went wrong, or what went right? And I think really, whether you're a student or a resident, you're going to learn more by mistakes than you are by seeing the perfect version of something.
Well, that's the nature of humans too, is we tend to focus on the negative. If you get a bunch of patient reviews, every month I get these patient comments in my inbox, and it's just like I'm rifling through, like, oh, great doctor, wonderful. And I'm just like, there's one. What is, oh, this, he said he was running behind and he felt rushed. then like that's the one you remember. And so it's interesting to just involve the human psyche in terms of like if you make a mistake in surgery or however whatever else, you're going to remember it more than maybe all those great successes, which isn't necessarily fair, but it's an interesting dynamic of the human psyche that we tend to focus on the negatives and ignore all the positives, which it should really be the opposite. You know, if you're getting great patient reviews, well, okay, there's a reason you're getting great patient reviews. It's just an interesting kind of dynamic there.
I think
um,
maybe somewhere in the middle might be nice. Like I did the
right.
same thing. If I see a review online and it isn't superlative, then I start thinking back, do I remember this patient? Do I remember what
Hmm.
happened? Could I have been wrong? Could I have done something different? I did exactly the same thing. I think I probably give others a little bit more leeway than I give myself. But at the same time, that other side of that is if you just ignore those things and just look at the perfect scores, the fives, you're really not going to learn anything new. You kind of have to look at both of them.
Yeah, I think that's reasonable. Let's go backwards for a second before we go forward. So you trained in Detroit. I've heard great things about academic training in Detroit just because of the wide range of pathologies. So do you feel like your training in Detroit was, helpful, setting you up for basically to be able to see anything that could possibly be? I feel like if you've seen everything that Detroit has to offer, then you've seen it all.
Yeah, it's very true. I mean, the pathology was kind of a little bit of the worst that you can see from that standpoint, which of course bad for patients, good for
Right.
learners.
Right.
The hospital that I trained at was is kind of on, it's on 8 Mile, so it's on the border
Oof.
of a really really good area. This very high sort of high economic,
Hmm.
socioeconomic kind of pattern, and then on the other, like almost the other side of the street is that the air like the movie 8 Mile is takes
Yeah.
place there.
Hmm.
So we would see kind of both, and it would give us a really well-rounded kind of perspective. My residency director, Dr. Marshall Solomon, was fabulous. He was really always looking to try to find the most experience that we can get, they always said you're going to see 95% of what you're going to see in practice, you're going to see here. And I would say he was right. Sometimes that 5% can get a little crazy in real life when
Hmm.
you see that something different. But
Yeah.
what they really taught us that I felt was so important was thought process, and not just listening to, such and such person. This is what they do. And so you have to do exactly the same way, like a cookbook. I've taken that same kind of perspective and tried to give that to whether it's people reading the editorials or if it's students or residents, that you have to be able to think through what you're doing because you're not always going to be in this situation that you've seen 1,000 times. Every situation is going to be slightly different. So it's
Yeah.
it's nice to have that thought process in there.
Yeah. They say youth is wasted on the young, which you have to get old before you can agree with that statement. But if you could go back to residency, you might double down and really kind of focus on certain things a little bit differently because it breezes by and you're just like, oh, I want to see that. And I got another ankle fracture. And it's like, you know, it might double down on some different things if you could go back and do it all over again. Yeah, it's but by the time it's over, then it's too late. You can't go back and relearn some of that pathology that you wish you would have spent a little bit more time on.
Definitely. Residency is too short. I mean, it feels like it's 3 years for somebody who hasn't gone into residency yet might seem like a long time, but when you're going through it, and then you look back, it's kind of a whirlwind, and you're right. You're just kind of stacking experiences on top of each other, and when you get a chance to sit and think about it for a second, it's pretty amazing that you get a chance to, but it goes by really fast.
Yeah, it really does. So, what courses do you teach at Western University? Are there some that you still kind of cling to that are kind of your specialty?
Oh, yeah. Well, so I would say that from a academic interest, my real passions kind of run where biomechanics and surgery sort of meet. I don't think there's enough discussion about that in really throughout podiatry at the university where we taught. So Western University is very different from most of the other colleges in that the podiatry curriculum is integrated. So there's one class of podiatry every semester, and it has each class has everything in it. So you'll have biomechanics, radiology, surgery, non-surgical, podiatric medicine. It's all embedded and it runs through the first 2 years of the student's education.
Mhm.
And so it's not like they don't have a biomechanics class, a radiology class, a surgery class. It's all integrated. So the idea being that if you can learn this method where you're receiving what it looks like in more real life situation, then you'll be able to apply that information easier when you start to get into clinical rotations. So I ran. So for me, for I don't know, I think I've taught pretty much all of them, but the class I kind of taught most commonly was a class that had trauma, podiatrics, kind of the more quote complex kinds of things. So it was that, but there was kind of a mixture of all those things in there. Dealing with ankle fusions, you still have to understand the rest of the foot, and you can't just forget about it. So
Right.
um, yeah.
I think that's interesting because sometimes one of the hardest thing is the clinical application of the foundational knowledge. So you start to learn things and then you can't learn step 2 before you learn step 1. You have to understand the basics before you can build upon that. And you can't understand surgery before you understand anatomy. That's a pretty good example. But trying to get students and eventually residents to apply the clinical information in a way that makes it make sense, I think is fantastic. And it's a little bit difficult to do because sometimes that comes with experience. Sometimes you don't understand the difference between a 3.0 and a 4.0 cannulated screw until you're in the OR and I hold it up and I say, look, this is that and this is the. Oh, okay. Well, yeah, okay, I understand. Or partially threaded, fully threaded. You have to like put your hands on these things. And then taking that clinical or taking that foundational knowledge and then understanding based on the fracture pattern, okay, well, on this patient, I'm going to use 4.0s or 3.0s, or I'm going to use locking screws or non-locking screws. So I think that's an important concept of transition from foundational knowledge to clinical application that is very difficult sometimes because I work with third-year students. So they're kind of right in that transitional period. They've had their first 2 years of school. They're coming out with me. We're going to surgery. We're seeing a lot of clinical pathology and trying to make that make sense. Sometimes happens quicker for some rather than others. But I think that's a tricky thing to get that to stick as they're absorbing all this knowledge so quickly.
Oh, yeah, totally. I would have to say that for some students and maybe to some extent even some residents, that knowledge transition it can be really difficult. There's when you're seeing a patient and after a while you get good at it, you stop thinking about all the little pieces that you just automatically do. And that can actually be a little difficult for the teacher because you're not thinking about all those things that you just naturally do. You know your series of questions you ask, you kind of know in a certain situation, you're going to approach it X way, but the students, they don't have that. And so it can be challenging for the teacher to go back and try to help a student apply a number of pieces of information into a treatment plan and have that make sense. And you're right, some students take longer than others to do it. I don't think it's impossible by any means, but I think
Yeah.
the key is really for us as teachers to see that a student is having trouble with that particular I guess you can call it a skill. I feel like it took me years before I could really understand that a student had problems applying a particular set of knowledge, and
Mhm.
maybe they were just overwhelmed by all of the details. I think that takes time.
Sometimes they need it explained in a little bit different way too. If you hear it one way over and over and over again, it may not click. And then sometimes you try to describe something a different way and all of a sudden things click. I think we've all had that in our life where you didn't really understand something. And then at one point you're like, oh, that's what that means. So I think
Yeah.
hearing things over and over again is helpful as well.
That's my favorite part of teaching. The thing I love the most about teaching is that moment where somebody goes
Hmm.
from not understanding to
Yeah.
getting it. And then,
Hmm.
yeah, that aha moment they get is just, it's really fun to watch that.
It is. I think it's kind of like learning a new language. I've always heard that when you learn a new language, you don't really know the new language until you stop translating everything back to English in your own mind, right? You don't like you said, you have to put all those little foundational pieces together, and you're still but eventually it all becomes a puzzle that fits together, and you can go see a patient and not have to think, okay, did I do neuro? Did I do derm? Did I do vascular? Like, and then eventually it just becomes the way that it is. I think that's interesting to watch it unfold before your eyes, having involvement in both the student level and then at the residency level as well.
Oh, definitely. I mean, if I could give a piece of advice to anybody who's teaching, especially those of us who've been around a while and are just, they've gotten good at whatever that is, and they just naturally do it, is to really stop when you're with a student, is to first remember that they are far behind you as far as the, kind of the timing and the experience. And then for you to kind of slow down and break up what you're doing into pieces, that can really help your learner to understand what you're doing better. They sometimes just, they can't keep up with somebody who has been around for a somewhat longer period of time or has a lot of experience, and we don't think about the things that we do often and that we get good at, but they're still in that phase, like you're saying, that they're working through the steps. You're going to put a lag screw in, they really thinking through the steps. They're not just
Mm-hmm.
just doing the thing and getting it finished. It's very different.
Mm-hmm. Yeah, I think that is, yes, I agree with you. Lost my train of thought there. You got me thinking about lag screws and started thinking through the steps of how to put a lag screw.
Right, exactly. That kind of is like a perfect example, isn't it? Like, you're in the operating room, you're doing on a whatever fusion procedure, and you just, you automatically, in your way of doing it, maybe you under drill first, you over drill, whatever, you go through those steps like naturally. You just know, you know if the drill bit is too small or too large, then
Mm-hmm.
somebody handed you the wrong thing, and it's all natural. But for a student and or even a resident who doesn't have a lot of experience yet, they're just really piecing through step by step, and it can be a bit of a challenge for somebody, especially if you have a time crunch for something like surgery.
Yeah, sometimes you can see the wheels turning. I really don't like the thought that I might be talking down to someone in terms of like educational material. Like, okay, we're going to do this and I'm going to put that in, I'm going to do this. And so I think sometimes I talk way above their head, and they'll just kind of say, the students, that is, they'll just kind of say, yeah, yeah, yeah. And then I'm like, wait a minute, let me go back. Do you understand that? What did I just say? And they're like, I have no idea. And I was like, okay, I need to know that you don't know. If you don't know, then I can't stop and go back and dial that in and give you more information. You have to be willing to be like, all right, I don't really understand what you're talking about right now. And that all comes part of like putting it all together.
Yeah, I'd say that's just good teaching, Jeff. I mean, you're stopping to give them a chance for you to figure out if they actually know what you're talking about.
Mm-hmm.
That kind of callback is really good. That you just, I mean, I think it's hard if the person who just likes to pontificate and
Mm-hmm.
they just keep going, and an hour later they're still
Yeah.
talking, and
Yeah.
the person's zoned out and they're gone, and they don't know or understand what you're saying. I think it's great to stop and look back on it. It makes perfect sense.
Yeah, part of it is is it catches me off guard though, because I'm talking about things that are rather complicated and uh difficult to understand, and then they'll still say yeah. And I'm like, wait a minute, I don't think you really, there's a small chance that you actually understand what's happening here. You don't just get to say yeah and we keep moving. So what is your goal with the articles from Present Podiatry? What are you, because obviously you have an educational background, but what's your goal with those, and reaching out to all the people that you reach out to?
Oh yeah, that it's an interesting question, because it's going to sound dumb after 20 years, that there really isn't a overarching goal. Like, there's some point we're trying to get to.
Mm-hmm.
When Michael and Alan asked me to do this, their thoughts were like, this is the day to day person who's, they're going through the training, and then when I became new in practice, what was it like? What's your day to day sort of like? And over the years, it's sort of become a bit of a diary. Just, this is what I experienced this week
Mm-hmm.
or over the last few weeks. So there isn't a goal like, if you're reading a book and you're trying to get to the end of a book and know a story. This was sort of like, this is what it's like for the average podiatrist who's in practice. This is what I'm seeing. This is what I'm thinking about. What about personal life? I've written some stuff about personal things. What have I learned? Where have I been? What am I doing? Odd stories like I mow my own lawn. So apparently people laugh at the fact that I'm mowing my lawn and what.
Really? What do they expect you to? I mow my yard. What do they expect you to hire it out?
Yeah, basically that's what people expect. Maybe that's I don't know if that's a California thing or not, but
That's my 45 minutes of peace and quiet.
exactly. I felt the same way, and there's you get a lot out of those simple things, but those experiences in life and in practice, teaching, whatever those experiences are, they become an opportunity to think about something a little bit deeper. A conversation with a colleague has you maybe question, like, oh, is that really right? Am I doing that thing right? Does it make sense? I'm a kind of a skeptical person, so people say stuff and I start asking questions about it. And
Mhm.
so the editorial has become this sort of avenue to sort of ask questions in a somewhat organized fashion. And maybe organized might be a little bit not true for in some cases, but having an organized way to sort of think about what you're experiencing I guess, seems to have worked over these 20 years.
Mhm.
The present folks haven't fired me yet, so I guess I'm doing okay from that standpoint.
You must be doing all right. It's an interesting way to absorb some educational and entertaining material, depending on the article, bit by bit. It's one thing to sit down and read a textbook. It's just not appealing at all to just sit down and try to absorb all this, whatever information it may be, all at once. Not that your material really fits into a textbook. Sometimes it's more thought provoking than kind of just factual information, set out there. But it's an interesting way to absorb the material on a bit by bit of slow, one bite at a time, rather than trying to swallow the whole sandwich. So I think it works that way.
Yeah, absolutely. Some topics lend themselves to a more conversational style, and then others are, like you said, they're a little bit more, I don't know, mundane or a little bit more academic. And the when I academic articles that I write, we try to keep it somewhat short. And I mean, some of them may seem like they're long, but like you said, like if you get into a textbook and it's this exhaustive, fully cited, you've got 300 citations and that kind of thing. Not everybody wants to hear that. So having something that's a little bit more concise, a little faster to get to a point, might give you some information that you can think about yourself and then use a little bit faster, that like on your next day. So we try not to go excessively long. Although I
Mhm.
have to say I probably run, I don't know, somewhere near 800 to 1200 words for the kind of the average one. Some things you just can't say in too short a time.
And it's interesting because you're also accruing new perspectives, right? Some of the people that read one of your articles today I was going to make you feel really old, but they were quite young when you started doing this. So they weren't reading podiatry articles when they were 5 years old, right? So you're kind of constantly accruing a new base of people who are absorbing this information. And so it's kind of, as your journey goes on, you're also building new people that are absorbing that information. So because one of my thought processes was, how do you not become redundant after that many articles over that many years? But the chances of someone who's reading it today having gone back and read all the old articles is probably not very high. Um, but it's an interesting to think about that you evolve, the people reading it are evolving, and medicine is constantly evolving. So why can't you keep coming up with new ideas and new points of view to dissect?
Yeah, absolutely. It's so true. It's just like patient care. Not every patient with plantar fasciitis is the same. They all have their own story, and they're something's different usually. It's the same kind of thing. Although I have to say, there have been a few times where I've looked back at what I wrote way early in my career, and I think, what were you thinking? That was ridiculous. So like have a
Yeah,
little bit more experience, and then you see that things change. And
yeah.
as a young provider, even from the residency standpoint, you get kind of cocky and you start thinking, oh, what do those old dudes know? They just, yeah, sure, they've been around, but I see them making mistakes all the time.
Yeah.
And you don't realize that that experience actually is really important. So
Mhm.
your perspective really does change over time. And so the same topic can oftentimes, despite it being the same topic, is really not redundant. And actually, you have a different perspective. And it's kind of interesting to see that.
Mhm. So, speaking of things kind of transitioning with time, how do you think that training, either both in the school or in residency, how do you think that training has changed since you were a resident?
Oh, that's a good question. I mean, I think in some ways it's stayed very much the same, and in some ways it's changed quite a bit. So the staying the same, I think the general idea of doing a lot of surgical cases, seeing a lot of patients in clinic, sort of examining what you're doing as you go and you go through your rotations. That really hasn't changed. That's been structure has been the same. 36 months of residency training. That part of things hasn't changed. I
Right.
think what without sounding too generational about this whole thing, what has changed are the people going through, and in a positive way. I look back and I think about the things that I did as a student and a resident, and then I see what our young students and doctors are doing, and they're honestly better than I ever even thought I would could have been. They're great. The things that they do, some of their thought processes they're very fast. Maybe they're just naturally fast, and maybe I'm slow, but they they pick up on things, I think, a lot faster. Their social interactions are, of course, very different. I mean, the internet had barely started when I was a resident. Like,
Mhm.
there were no smartphones. We carried pagers. There's essentially not much of an internet. It was the bare minimum back then.
It's pretty
And
boring.
yeah, very much so. And what is available for them now is huge. And I see that those residents that I work with, they pick up on things very fast. Because they have so many resources, when you tell them something, they are just they're looking for the original article, then they find it really fast. I had to look through books and magazines and go to an actual library in order to find stuff. It's not
Yeah,
even like that anymore. So that has really accelerated
for
their
sure.
capacity to learn and do the things that like it would take me a second year to do anything of any complexity, say from a surgical standpoint, and I can do a flat foot reconstruction with one of my first year residents, and they do great. So
Mhm.
I think that's the thing that really has changed a lot.
Yeah. One of my students the other day showed me a site where it's AI and it'll aggregate all the research articles. So you type in a topic and it'll aggregate all the research articles and pull it all together into kind of some concise findings. So you can research a topic in 10 seconds. You used to at least have to go find the art. You're talking about going to the library. Now, recently, you would at least have to find the article, read the article. Now, with AI, it can kind of aggregate all the articles, all those 7, 10 articles you were going to flip through and try to read. It's going to bring all that information together almost instantly. It's almost not fair.
Yeah, absolutely. I've started using AI a little bit more on the academic side of what I do. We don't have AI with our electronic medical record system at work yet, like that kind of thing. But on the academic side, absolutely. Like you said, you can ask a question of it and it can pull up resources, it can give you suggestions in seconds. But I think that doesn't mean that they don't have to read these important articles or be able to examine a research paper and determine if it's legitimate. If a student or a resident were to do that and then all they did was get a couple quick bullet points, I think when they speak to an attending who has been around the block a while, they're going to look like they have a shallow understanding of it, even with the use of AI.
Yeah, I agree. It helps to read the full article and get the foundational understanding of what was happening in the paper. Now, it takes a lot longer and it's not as instantaneous, but I agree with you. Do you think that the attention spans have changed the learning styles? We're talking about AI and giving you instantaneous information. Do you find it more difficult, less difficult, or the exact same in order to keep the attention of some of the current students or residents when you're trying to teach?
Yeah, I would have to say it's probably a little bit more difficult to keep attention. So it then matters sort of what you're doing with your education. I think
Mm-hmm.
the classic journal club where some poor soul has to tell us every step of a research study, go through all of it, the methodology, the outcomes, and then
Yeah.
you have a discussion about it in isolation from anything else is so boring that I don't see a lot of people getting a lot out of that anymore.
Yeah.
But when you link those kinds of things to their experiences, they had some clinical or surgical experience with a patient, and then there's this X research study that you can use to talk about it. I think that makes it more real, and I think that's what our learners want. They want to have those real experiences, and then yeah, they can apply their research, but I think that has to be integrated. And if you don't, then you're missing out on the probably the most important part of clinical education.
Mm-hmm. Because of the changes that you've seen over time, have you found yourself having different expectations of the students and the residents? Meaning, if you, in the olden days, if someone used to have to go to the library and look up all the articles, you wouldn't expect them to, you know, bring that information back to you so quickly. But now you ask a student a question or a resident, they're coming back to you 10 minutes later and saying, okay, I looked it up and here's all the information I could find. And so do you have different expectations that have changed over time?
Yeah, I don't think um, my methodology of asking questions and expecting answers has really changed. Like if you're in clinic and you have a busy clinic and you ask a learner a question, I don't think you can in reality expect them to just whip out their iPhone and call up such and such classic article and give you excuse me, give you a discussion.
Mm-hmm.
But a day later, absolutely. What I have seen with a number of my sort of clinical and education partners is that they want to see email responses answer their questions from something that came up during a clinical experience. I'm still old school enough that I do not ever want to see an email about an answer to a question. I want a person to be able to tell me in
Mm-hmm.
person, upfront. We can talk about it. Anybody can cut and paste into an email. So
Right.
I tend to be a bit old school on that part of things.
I think at the end of the day, that's just going to make them better. Anybody can copy and paste something from AI or an article and be like, here, I found this. But if you look them in the eye and you can really find out, do they truly understand? Because that's our goal at the end of the day, not to make people feel bad for not knowing something, not to, I'm not, I don't ask the students 10,000 questions and trying to make them cry. It's to get them to learn and understand what's happening so that when they go out into the real world, they're performing good quality medical care. But yeah, it's an interesting process, isn't it?
Absolutely. I would say my own personal focus is probably more on how they think and how they're approaching taking care of a patient rather than some rote knowledge about such and such. I will commonly ask somebody comes in, they present a patient, give me a history and a basic physical. And my typical first question is, well, why do they have that diagnosis? What is it about that makes them have that diagnosis? That is not a first order, answer a question about a bunion. It's really, what is it that supports your diagnosis? So again, it really gets to the thought process, and that's kind of what we spend probably the most amount of time on.
And that's the hardest thing to get to is utilizing all the foundational knowledge, like we said, clinically applying it and doing it quickly and coming up with reasonable diagnoses. Sometimes the students just shout out things you're like, what? No, like, maybe, but
Yeah, definitely. That's it's like the school kind of method. That when you're testing somebody in a school-based clinical exam or something along those lines, you have to say, student stated 3 differential diagnoses for this complaint, and
Mhm.
you don't have the luxury to make it like always 100%. They're fully realistic, but in clinic it's a different story because
Yeah.
a person comes in with midfoot pain or something like that, and they have to support a diagnosis, it really gives you the opportunity to go through that thought process and test it.
I've had this kind of weird juxtaposition of a PA joining me and trying to train on the job a PA who has orthopedic knowledge, but not necessarily podiatry knowledge, but also training the students. And it's really an interesting thing that I've noticed of trying to teach a PA certain things about, okay, medial pain could be, deltoid, posterior tibial tendon dysfunction, could be tarsal tunnel, it could be, all these other things. But here's what we're going to look for each of those things. And it's kind of like the Cliff's Notes version of things that I'm teaching to the students, but it's very difficult to try to give people all of the information without them having, lower limb anatomy, biomechanics, and all the things that we build upon as we grow. So it's just been interesting for me to try to, I got one line teaching this person this way and another line teaching this person this way. It's tricky. It's hard.
Yeah, it is. So I think it's really interesting to try to see like how do you teach that person to get to a point where they can, kind of do that sort of average podiatry.
Well, it's very difficult. Luckily my PA has experience in urgent care and orthopedics and family medicine in the past. And so, he picks up a lot of the simple things very quickly. It just gets extremely complicated when we're trying to delve into these little finite details of like lateral column overloading and subfibular impingement and all these things. Like I can't, it's just, you're not going to get that far. So figuring out and shuttling which patients into which go to me, to go to him, or something that we kind of combine our efforts and see them together. It's a work in progress. It's only been about 9 months or so.
Well, it's great that you have the opportunity to do that. That's pretty cool.
Yeah, it really helps me out in terms of patient volume flow. And so I get to a point where I don't necessarily want to see more patients, but if we bring in another podiatrist, that's direct competition for me. So it's kind of a way to keep those patients under my purview, but still have some extra help.
Yeah. Yeah, that's good. I'm in a practice with a solid number of podiatrists. I would say it's one might think that you're in direct competition with those folks, but when the practice is set up to provide enough patient volume and you're in that situation, I think that's a plus. I mean, it's really cool to see. Obviously, most of my colleagues in private practice are younger than me. I guess that's pretty much the nature of the beast. As you get older, they start getting younger, right?
Yeah.
But it's really like we're not, I don't know that we're really in competition with each other. And from a practice management standpoint, I think you actually tend to do better as you go and you increase the number of podiatrists. But I think it's probably very practice specific and
Mm-hmm.
geographically specific. If you're in a rural area, you may not be able to have maybe more than one or two podiatrists at the most. And I could definitely see where like that kind of situation might
Mm-hmm.
lend itself towards like a greater competition.
Yeah. I'm at a multi specialty clinic. And so it gets a little bit complicated. And it's the best scenario for what we have going right now. If it get too busy, then yeah, of course, we're going to have to hire someone else and figure out how to split those patients up. But
Yeah,
yeah, in
yeah. I mean,
private practice, yeah, go ahead.
I think it's really unfortunate that we podiatrists are limited in the sense that we're like in some of these states we're talking about, we can't hire a physician's assistant. I think it's kind of ridiculous. It's a whole old argument about podiatrists, whether we're physicians or not.
Hmm.
I think it's really kind of a discriminatory practice. If you're, it's not like we're hiring a PA to pre-op our patients and do an H&P for surgery. We're not asking them to practice outside of our own scope. They're practicing within our scope, so we should be expert enough to be able to handle a PA working within a podiatry practice. It's just,
Hmm.
it's one of those things. Podiatry clearly is, we've taken huge strides by really amazing people who've really put the time and the work in to prove that we are who we are. But the fight's still not over. Clearly, there are situations where not every state is going to treat a podiatrist fairly, and there's still a few states with scope of practice issues, and so it's not over yet, I think.
I agree. Let's talk about biomechanics. And you said that biomechanics and how it applies to surgery is one of your favorite things to teach and talk about and think about. So, what are some of the things that you think about when you start trying to incorporate biomechanics into surgery? Because biomechanics, if you dive too deep, I mean, I just think I'm probably not smart enough to understand all the things that come along with it. But can you give some people some examples of how you think that biomechanics and surgery are so closely interrelated?
Yeah, definitely. Jeff, I totally agree with you that there's a scientific aspect to biomechanics. As a friend of mine, Darrell Phillips says, it's the mechanics part of biomechanics. Is very much there's a science there. There's numbers. I start hearing those things and I start to fade out. Really, where I have noticed there to be a bit of a detriment is to look at surgery. And when I went through school and was first in practice, the idea of biomechanics was orthotics and surgery was surgery. And the two things were totally separate. And there was really kind of no mixing of the two. And so where I have spent a lot of, I guess, intellectual time sort of thinking about it is, can those two things be the same? And so what I've talked about for maybe a few years now, is where they meet. And if you think about these things, that they're really two sides of the same coin. Using an orthotic is very similar to certain surgical procedures. Modifications to an orthotic will apply forces to a foot, and exactly the same way something surgical is the same. So like, for example, a medial heel skive increases the force of the orthotic against the foot and it causes supination. Well, that's very similar to a medial calcaneal displacement osteotomy, where you're just medializing the calcaneus and now you're getting ground reaction forces to do that instead. It's a bit of a more powerful way for that to happen, but yeah, because there's more to it than that, right? There's more effect that your surgical procedures may have.
Yeah.
So it's that kind of example is the thing that I try to spend a lot of my time on. So if you then have to have a decision making process. How do I decide to do that procedure versus, say, an Evans for a flat foot reconstruction? When I went to school, I was taught an Evans was a transverse plane procedure. It turns out that it's not. It's a triplanar procedure. As
Yeah.
we've grown in our understanding of biomechanics, we see that it has a powerful effect, and where you apply that, I think, is important. And so a lot of people are taught, you see this change on an x-ray, you do this particular procedure, but really that doesn't lend to any real thought process. That's really just kind of a if then kind of thing, and it's just a kind of a cookbook. So what I have spent my time on is really looking at how can you decide whether to use that or whether to do a fusion procedure of some sort. How can we apply that? And so what I teach is that same kind of thought process. I try to simplify it. Maybe like what you're saying, um, it gets a little complicated after a while, and it's easy to fade out. So if you try to sort of break down your thought process into a sort of simpler method, you can globally apply that. So I teach this kind of idea where you have like kind of three cardinal rules where you're taking care of a patient. You do a history and a physical, and you try to figure out what anatomy is damaged and then what biomechanics are behind that. You do your exam, you find out such and such is the problem, and then you treat what that problem was. And the only ways that we really have to do that, whether it's surgery or not, is to change forces or positions. And that's it. That's really all we have. That's all you can really do. We don't have any magical way to make a ligament become functional when it is torn or something. We just really just like surgical correction, that kind of thing.
Mm-hmm.
So you go through that process and you think, okay, well, from a surgical standpoint, if my patient has adult acquired flat foot, then I want to apply certain forces. And how do I do that? You can then pick those procedures in a sort of more thoughtful way. And in the same way, you could do the same thing with a foot orthotic or a brace. What modifications to an orthotic are going to apply forces to the foot? And I found, as I have gone down that road where I sort of think about that kind of more simpler style, I feel like I get better results kind of in the long
Mhm.
run. Which
Yeah.
yeah, so it's that kind of thought process. I think if when there's a sort of a bridge between biomechanics and surgery, that's kind of where I have felt like I have sort of fallen into that kind of role. Like, how do you decide really where to make, uh, where your decision making lands you as far as what kind of treatments you're going to do?
Yeah, I think that's an interesting viewpoint in that biomechanics and surgery are really not as different as you might think. And like you said, you're looking at an x ray and you're trying to figure out what surgery to perform. I think about that as more of the static. But really, you have to think about biomechanics because the foot is dynamic. It's not static. It's just not one x ray, not one lateral x ray with a calcaneal inclination angle of X. It's more so what's that foot going to do when that patient gets off the x ray block and walks out the door. And so it gets far more complicated than I think people appreciate than just looking at a simple x-ray and measuring angles and saying, okay, we're going to do this and this. Not saying you shouldn't do that because you can use that to add it to the global knowledge of this specific patient, but that patient is going to start moving and dynamically things are going to change. So understanding
Yeah.
the biomechanics that comes with those dynamics, I think is very important. Not to say it's not complicated because it very much is, and I think that turns some people off. But I think understanding it is very important.
Yeah, but I think, some people hear the word biomechanics and they just turn off. But really, if you look at a lot of the research that's out there, there are some of these classic articles that, yeah, yes, some of them are pretty, they can be pretty complicated, but they're not that bad. They're not that complicated. Most of the people who are going through this are reasonably intelligent people. But
Uh-huh.
if you say pick studies about surgical procedures, and you look at these things from the what's termed the kinetic or kinematic effects, the positions and the forces around it, and you look at, say, a cadaver study, and they know that doing a certain procedure will have an effect on the rest of the foot, and they report on that. Well,
Right.
you don't have to be the expert on that in order to say I can use that information to determine if I'm going to do a certain procedure on a patient. So just as a simple example, the medial calcaneal displacement osteotomy has been shown in research to decrease strain and forces that go through the talonavicular joint and along the posterior tibial tendon. So if you're going to treat somebody with that procedure, you can think to yourself, okay, well, I know that there's this research that shows that I will decrease strain on the posterior tibial tendon. Well, that makes sense. If I'm going to treat somebody who has PTD, that's exactly what I want to do.
Mm.
So there's some evidence that says that particular procedure can do that thing. And similarly, on the opposite side of that, every surgical procedure might have a negative effect in some way. So probably the classic one is, are you going to cause calcaneocuboid joint arthritis or strain in that joint when you do an Evans procedure? And how far can you push an Evans before you start to have those problems? There are research articles that talk about that. And again, I think just reading through those articles, it doesn't even have to be in that full detail. Just reasonably questioning, make sure that the methodology is okay. And then you say, okay, well, I see there's this, I can only push this maybe, I don't know, 1.2 centimeters at the most. And then I'm going to start getting into that realm where I'm going to start having CC joint arthritis. I don't think you have to be the, biomechanics expert of the world to read an article and say, okay, well, I can see where this procedure is going to be beneficial in this particular situation. I think people get afraid to look at articles like that and just say, okay, well, what are they really saying? Is this thing helpful or not? So I would say anybody who's planning to do surgery, they really should understand the biomechanics. Like you said, the patient doesn't stay still after you're done doing their surgery. That'd be great. We'd be hand surgeons then, right? At that point, they're not walking on it.
Yeah.
But that's not where we are. We have to very much concern ourselves with function, and you just take all that information and then try to make a rational decision for the best outcome for your patient.
Absolutely. Well said. I appreciate your insight into all of this. I think this has been fantastic for people to hear. Teaching at the school, the residency, biomechanics, everything. I want to thank you for hopping on with me tonight.
No, it's been my pleasure. Thank you very much.
So if anyone wants to find out more about what it is you do, podiatry.com, you guys got to that one early, or they did, and then hired you. But podiatry.com,
Yeah,
that's the one.
they did. They did that great.
So they could find you at podiatry.com with your, you call it a blog? What do you call it?
Yeah, I mean, when I first started, I was an editorial. Now it's I guess a blog is probably the most legit way of talking about it.
So hop on podiatry.com, look up Dr. Shapiro. Thank you for joining me today.
My pleasure for being on. Thank you so much.
Absolutely. Thanks everyone for joining us on this episode of Pod Patrol with your host, Dr. Jeff Dikis. We'll see you next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.